Hey everyone, welcome to the UNC Neurosurgery Med Student Primer Series. I'm Marty Piazza. I'm one of the neurosurgery residents here, and today we're going to be talking about some thoracolumbar fractures. Obviously, this is not going to be an exhaustive review, but it's going to give you hopefully some context and some clinical background that you should know about patients that have these injuries. Before we discuss the spinal fractures and injuries that can occur in this region of the spine, let's talk a little bit about the spine anatomy itself. Now, as you know, the spine is divided into several portions: the cervical, thoracic, lumbar, and sacral spine. Today, we're going to be focusing on the thoracolumbar region and the lumbar region. And when we say thoracolumbar spine, we're specifically bringing our attention to the junction of the thoracic spine and the lumbar spine. And the importance is that there's transitional anatomy here, putting it at risk for potential injury. The thoracic spine is characterized by the connection of the rib cage with the thoracic vertebra via the costal facets. And together, the ribs and the spine create this very biomechanically stable construct. And so oftentimes fractures that occur here are already braced because the rib cage is supporting it, although there can be unstable fractures that occur in the thoracic spine. The last two ribs of the thoracic spine are floating, meaning that they don't have a direct articulation with the rib cage and the sternum, and this creates a transitional point where a rigidly fixed thoracic vertebra at that level of the true rib is followed by a mobile low thoracic and lumbar vertebra. And these factors impose unique properties to each vertebra and allow for implications with respect to spinal stability. So in the lower thoracic spine and the high lumbar spine, those bones in particular are at risk for injury. When evaluating a patient with thoracolumbar fractures and a spinal cord injury with respect to stability, you should consider using the TLIX score, which is a great way to help determine if a patient is a surgical candidate or their injury can be managed non-operatively. And this score is based on three things. The first is the injury morphology, and that's determined by radiographic evaluation. And then the second one is posterior ligamentous complex integrity. And the posterior ligamentous complex is composed of the supraspinous ligament, the interspinous ligament, ligamentum flavum, and the facet joints. And then the third component of this scoring system is the neurologic status of the patient, and that's determined by our neurologic exam. A score of less than 3 can be managed non-operatively. A score of 5 or greater should be managed with surgery, and then a score of 4 can be managed with either non-operative management or surgical intervention, and that's when the surgeon's clinical judgment has to come into play. Of note, oftentimes these patients will show up with just a CT scan, and the posterior ligamentous complex isn't something that we can see on CT. Sometimes there's things that we can use to infer the integrity of the ligamentous complex, but if there's any question or you're not sure, an MRI is a better imaging study to assess this, particularly in a patient that has kind of a borderline score or a 4. In a patient that has negative CT imaging, but there are neurologic deficits present, you should always get an MRI to make sure that there's no soft tissue compressive lesion or a herniated disc that isn't visible on CT. Another scoring system we commonly use in the setting of spinal injury is the ASIA classification, and this is a score that's based solely on the neurologic exam. It's almost all of the fracture types that we're going to discuss can present with either no neurologic deficit or very significant neurologic deficits. So this is very helpful when you're describing patients to your attending or resident. An ASIA A injury is a complete spinal cord injury where there's no movement and there's no sensation below the level of the injury, whereas an ASIA E is a patient that has no neurologic deficits. Their motor and sensory function are normal. This is something that You definitely need to know when you're evaluating a trauma patient, as I mentioned. And it not only does it help you determine if a patient needs surgery, but it also helps you determine the timeline. And what I mean by that is that someone with a complete spinal cord injury doesn't necessarily need to go emergently right now to the operating room because they've already lost function, unfortunately. They should go at the very latest the next day, but it's not a true emergency where you need to roll them to the OR right now. An incomplete injury denotes that there's potentially salvageable function, and these patients are true emergencies, and they need to go to the operating room if they're stable from a hemodynamic standpoint. When discussing thoracolumbar fractures, we talk a lot about spinal stability, and there are many classification models, but we use the Denny system, and that's the one that's most widely used and probably the one you learned in medical school. So in this system, there's 3 columns. There's the anterior, middle, and posterior columns. The anterior column, which is in yellow here, is made up of the anterior longitudinal ligament, or the ALL, the anterior 2/3 of the vertebral body, and the anterior 2/3 of the intervertebral disc. The middle column consists of posterior 1/3 of the vertebral body, posterior 1/3 of the intervertebral disc, and the PLL, and you can see that here in green. And then the posterior column is everything else. So everything posterior to the PLL, and that includes the pedicles, facets, articular processes, ligamentum flavum, and then the neural arch and connecting ligaments. In general, if there's involvement of only one column, the fracture is not destabilizing and does not require surgery. This includes anterior compression fractures and isolated posterior column injuries like TP fractures, articulating process fractures, pars fractures, spinous process fractures, and laminar fractures. So let's stop there for now, and then we'll pick up next time talking about different types of fractures and treatment paradigms for them. So let's go over different types of fractures here.